Hello, my name is Julian Sanchez. I'm a second-year internal medicine resident at University of Illinois Hospital in Chicago, and I'll be presenting an interesting case that I saw while I was in internal medicine wards. The title of my poster is CKD, COVID kidney disease, which gives a clue into what we'll be discussing. COVID-19 has quickly affected the entire world, leading up to 19 million infections and over 700,000 deaths as of August 2020. Acute kidney injury, or AKI for short, affects 25 to 40% of critically ill patients with COVID infection, especially in those with underlying comorbidities, and is considered both a marker of disease severity and a negative prognostic factor for survival. In immunocompromised patients, the development of AKI can actually be as high as 50%. In this poster, we'll present a case of an interesting finding in an immunocompromised patient with COVID-19 infection. Our patient was a 56-year-old woman with hypertension and end-stage renal disease secondary to hypertension who received a renal transplant in 2012, and she presented with a 3-day history of abdominal pain. Her pain was intermittent, it was sharp and localized in the middle of her abdomen, and it was associated with non-bloody loose bowel movements, nausea, fatigue, and mild shortness of breath. Her vitals were stable on admission, and her physical exam was only notable for a tender left-sided abdomen, but no guarding, no rebound, or no tenderness over her graft. So initially she had a CBC which was unremarkable, and her creatinine was only notable for an elevated creatinine, which was actually 2 times her baseline. Her initial creatinine was 5.84 milligrams per deciliter compared to a previously recorded baseline of 2.3 to 2.8. We can refer here to Table 1 to review some additional results. She had her nasal swab point of care for COVID, which was positive. Given that she presented with diarrhea and abdominal pain, we checked for C. diff PCR, which was also found to be positive, and given her immunocompromised state, BK virus, CMV, and EBV PCRs were all checked, and as you can see here in Table 1, they were all negative. In order to assess her AKI further, a renal ultrasound was done, which showed a patent transplant renal artery, and negative for hydronephrosis, therefore suggestive against a post-renal AKI. An abdominopelvic CT was also done on initial presentation, which was negative for acute abdominal changes. Once her C. diff infection was known, oral vancomycin was started along with IV fluids, but despite the IV hydration, her creatinine remained high, which prompted us to get a renal biopsy to assess intrinsic changes. This biopsy revealed tubular injury and chronic changes of glomerular endothelial injury, suggestive of transplant nephropathy, of ATN, acute tubular necrosis. Additionally, and very interestingly, viral particles ranging from 50 to 70 nanometers were present in the glomerular endothelial, peritubular capillary endothelial, and tubular epithelial cell cytoplasm consistent with her COVID infection. Previous publications on post-mortem analysis of renal tissue have also detected viral particles in the cytoplasm of renal proximal tubular epithelium. However, it is uncertain if the COVID infection had a direct effect on the worsening of the function of the transplanted kidney, as our patient's renal function was already deteriorating even before the COVID diagnosis, although a multifactorial etiology could have taken place. As previous articles have hypothesized, it's possible that viremia causes endothelial damage in the renal tissue and contribute to acute kidney injury. Research is needed to understand further the disease development of COVID-19, and the findings that we're reporting today can help elucidate the extrapulmonary pathogenesis of COVID. Thank you for your time.